The following podcast is part of a certified educational activity titled Target Practice, Understanding How Parp Inhibitors Take Aim at DNA Damage Response Mutations Across Solid Tumors, featuring Dr. Susanna Banerjee, William Gradishar, and Maha Hussain. Access the entire activity and complete the post-test at peerview.com/VHU860. Downloadable slides and practice aids are also available.
Hello, and welcome to Target Practice, Understanding How Parp Inhibitors Take Aim at DNA Damage Response Mutations Across Solid Tumors. My name is Dr. Susanna Banerjee. I'm a consultant medical oncologist at the Royal Marsden NHS Foundation Trust and a reader in women's cancers at the Institute of Cancer Research in London. I'm delighted to be joined by Dr. Maha Hussain and Dr. William Gradishar from Northwestern University Feinberg School of Medicine in Chicago. So I'm really excited about this educational session because we're bringing together how Parp inhibitors have transformed the care of our cancer patients across tumor types. And the focus is going to be on the clinical trials that have led to this practice changes. So moving on to the key sections of this session together today. This is really a masterclass and practical toolkit session. We'll be covering the latest on Parp inhibition approaches in ovarian cancer, advances in prostate cancer, and also breast and pancreatic cancer. So I'm going to kick off by talking about ovarian cancer. And as you'll see, Parp inhibitors have revolutionized the care of women with ovarian cancer. And I hope to take you along this journey about where we are in practice in the next 30 minutes or so. So first of all, I'd like to just mention how Parp inhibitors work. It's important to remind ourselves of this. And this is a very simplified schematic of one of the key Parp inhibitor mechanisms that really took force, back in 2005 with the preclinical data on Parp inhibitors, and that's the concept of synthetic lethality. But it's really important for me to highlight that we now know there are other mechanisms whereby Parp inhibitors have activity in our patients. And that's really also relevant not only for efficacy, but when we're talking about Parp inhibitor resistance mechanisms and how we're going to overcome that. So a simple way of describing the most commonly described mechanism with regards to with synthetic lethality is summarized below. So DNA damage happens continually and can form single-strand breaks. Parp inhibitors impair base excision repair. And so when DNA replicates, DNA double-strand breaks can be formed, or replication fork collapse can occur. Now, in a normal cell with functional homologous recombination pathway, so HR-mediated DNA repair can occur and the cell survives. But in an HR-deficient tumor cell, for example, those with a BRCA mutation, there's impaired homologous recombination-mediated DNA repair and the cell dies. And this describes the concept of synthetic lethality leading to tumor-selective cell death. So other mechanisms that I mentioned earlier include Parp trapping, NHEJ activation, and impaired BARD1 BRCA recruitment. And these have been comprehensively described in a number of reviews for those that are interested to find out more about this. So this was really the pivotal preclinical data back in 2005, back-to-back Nature papers that showed elegantly the activity of Parp inhibitors in BRCA-deficient cancer cells. And what we see is the exquisite sensitivity of Parp inhibitors in this BRCA-mutated situation compared to the BRCA wild-type situation, with 1,000 times more sensitivity to Parp inhibitors. I was very pleased to witness this work that you see here with Farmer et al. At the Institute of Cancer Research. And that really led to the early phase studies, the phase 1 studies, and then the early phase 2 studies across breast cancer and ovarian cancer. And then you'll hear the rest now in terms of the individual tumor types. So in terms of ovarian cancer, what's the clinical relevance? Well, high-grade serous ovarian cancer is the most common subtype of ovarian cancer that we see. And the relevance of homologous recombination deficiency repair and BRCA mutations is illustrated here. Approximately 50% of women with high-grade serous epithelial ovarian cancer have evidence of homologous recombination deficiency. And there are a number of molecular aberrations which lead to this, as illustrated in this diagram here. But BRCA1 and BRCA2 mutations are the most common alterations leading to homologous recombination deficiency, or HRD. Around 16% have a germline BRCA mutation, and an additional 4 to 7% have a somatic BRCA mutation, so mutation in the tumor, but not in the germline. And this really led to the notion in clinical practice of the essential need of BRCA mutation testing in routine clinical practice. But Parp inhibitors have clinical activity beyond those related to BRCA mutated ovarian cancer. And that's really where this diagram comes into play, where we have the HR deficient population as well as the possible HR deficient and HR proficient. And I'll talk about this in relation to clinical trials now. So I'd just like to highlight the 2020 ASCO guidelines for genetic testing with ovarian cancer, which alludes to what I've just said, that germline testing for BRCA1 and BRCA2 and other cancer susceptibility genes is recommended for all women with ovarian cancer, epithelial ovarian cancer, regardless of clinical features or family history. So back in 2013, we did a pilot of BRCA testing in our clinics, in the oncology clinics rather than genetic clinics. And we found that 16% of women had germline BRCA mutations, and more than 50% wouldn't have had testing with the previous criteria because there was no family history or personal history of cancer. And then also, of course, the somatic tumor testing that I mentioned, recommended for patients that don't have a germline pathogenic or likely pathogenic BRCA mutation. Okay, the key point, and we may come across this later in the questions, is about timing of testing. It's important to do this at diagnosis because, as you will see, this really changes practice in the first-line setting in ovarian cancer. But what about homologous recombination deficiency? What do we mean by that? Well, I've shown you the diagram a few slides ago about the range of molecular abnormalities that could lead to homologous recombination deficiency. But how can we measure this? So we need assays to do this. And what I'm describing here are two assays that are companion diagnostics for Parp inhibitors. So firstly, the Myriad My Choice assay, which basically measures, assesses somatic or tumor BRCA mutations, as well as GIS, genomic instability score. And this effectively looks at loss of heterozygosity, telomeric allelic imbalance, and large-scale state transitions. And together there's a score that takes into consideration tumor BRCA mutation status as well as this score. So if the score's 42 or above, then it's deemed HR deficient. And if it's less than 42, no BRCA mutation, HR proficient. The relevance of this will be clear when I show you the clinical trials. There's also the Foundation 1 loss of heterozygosity testing, which has been used in the clinical trials of Rucaparib, for example. And we also need to think about, and you'll hear about this across the other tumor types, actually testing for other HRR pathway-related genes. We've talked about BRCA, but also the non-BRCA genes, such as RAD51C, RAD51D, BRIT1, ATM, CDK12, CHEK1 and CHEK2. But to date, in ovarian cancer, in terms of companion diagnostics and looking at efficacy according to molecular profiling, it's actually the HRD assays as well as BRCA mutations that are meaningful, at least in the first line setting. Okay. So this slide summarizes where we are with FDA-approved PARP inhibitors in ovarian cancer. I think it really shows the progress, how things have been spearheaded since the original preclinical and phase 1 trials to the approval in 2014, initially of olaparib for germline BRCA mutated recurrent ovarian cancer, and then moving on to rucaparib in the BRCA mutated space, and then the concept of maintenance therapies for PARP inhibitors in BRCA mutated population and then beyond. And then more recently, in the last 2 years, the first-line indications, which I will talk through in the next section of my presentation. As you will see, there is approvals according to BRCA mutation status and indeed HRD status. For example, niraparib in recurrent ovarian cancer as a treatment approved in 2019 in HRD positive ovarian cancer. This slide is an expansion of what you've just seen, giving more detail of the treatment indications across the 3 PARP inhibitors that are approved in ovarian cancer. And so illustrating the dosage, the frequency of treatment. For example, olaparib is 300 milligrams as tablets twice a day, rucaparib 600 milligrams starting dose twice a day, and niraparib either 200 or 300 milligrams once daily. And the approval dates are there. So here are the 3 key studies that have transformed the management of patients with newly diagnosed advanced ovarian cancer. So SOLO-1 of olaparib, PRIMA of niraparib, and PAOLA-1 of the combination of olaparib and bevacizumab. And I'm going to talk you through this data now. So SOLO-1 was the first study to report of a PARP inhibitor in the first-line setting in newly diagnosed advanced ovarian cancer. So patients with stage 3 or 4 disease that had had a complete or partial response after platinum-based chemotherapy, which is standard of care, surgery. They had to have had a BRCA mutation, either in the tumor or in the germline. And patients were then randomized to receive olaparib or placebo as standard of care. And I'd like to really point out that the treatment duration was 2 years if patients had no evidence of disease at the end of that 2-year period. And if there was some disease, then patients could continue. And that's relevant when I show you the results going forward. The primary endpoint was investigator-assessed progression-free survival. Now, these were the initial results presented at the ESMO presidential session back in 2018. Just to put this in context, we haven't seen this kind of improvement in first-line treatment of ovarian cancer, and these really were unprecedented results. So what we see here is that at 3 years, 27% of women were progression-free in the placebo arm versus 60% progression-free at 3 years. The median PFS was 13.8 months and not reached in the olaparib arm. We need to bear in mind that patients with ovarian cancer and BRCA mutations are considered those to have had to have a better prognosis. So these were the best patients, having had surgery, responded to chemotherapy, despite having advanced disease with BRCA mutations. And we can actually see in this prospective first-line study the rates of relapse here in both the placebo and olaparib arm. Now, what was very striking, and I was very pleased to present this data, the 5-year follow-up of SOLO-1 post-hoc analysis, which I presented at ESMO a few months ago in 2020. And now we see at 5 years follow-up that the median PFS is 56 months versus 13.8 in the placebo arm. And I just wanted to highlight the 2-year treatment cap. And if you look at these curves, they remain separated beyond when patients stop olaparib maintenance treatment. This is very encouraging. And the FDA approval for olaparib was back in December 2018. for women with a BRCA mutation having responded to first-line chemotherapy as maintenance treatment for a duration of 2 years. We always have to consider side effects when we're talking about treatments that may be long-term in particular. The side effects that we saw in the SOLO-1 study were similar to what we see across Parp inhibitors: nausea, fatigue, vomiting, anemia, the majority being low grade, but grade 3 anemia, as you can see, over 20%. It's really important when we're counseling patients to highlight side effects of Parp inhibitors and management in terms of supportive measures, checking if there's reversible causes for anemia, for example, iron deficiency, for example. Exercise can really help with the fatigue. I'd like to highlight that 64% of women in this study remained on the starting dose, and the key times of dose modifications was really in the first 3 months. This is the safety profile that you see on the far right of the 5-year follow-up, and it's reassuring to see that there were no new adverse events reported at that time. Importantly, one of the rare effects that we see in placebo as well as Parp inhibitor treated patients is the rates of MDS and AML. And reassuringly, in the 5-year follow-up, there wasn't an increased rate, and it remained under 1.5% in the olaparib treated arm. So moving on to PRIMA. So this was the first study, to look at a Parp inhibitor in the first-line setting, so Parp inhibitor alone, in patients beyond those with the BRCA mutation. So again, patients need to respond to chemotherapy. The population in this study generally had more high-risk disease, and they were randomized to receive niraparib or placebo. I'd like to just point out that during the study, the dose of niraparib was tailored according to the patient's body weight and platelet count. So those with a weight under 77 kilograms or platelet count under 150 started at 200 milligrams rather than 300. And here are the practice-changing results. What you see in the HR deficient population and also the overall population, you see an improvement in PFS with regards to the endpoint there. And as you see on the next slide, we divide this a bit further into HRD BRCA mutated, HRD wild type, and also HR proficient. There's a statistically significant benefit in all those groups, although the magnitude of benefit is greatest, as you can see, in the BRCA mutated HRD and then the BRCA wild type, and then hazard ratio 0.68 in the HR proficient. And this led to the approval, basically irrespective of BRCA or HRD status of niraparib in the first-line setting. So just to highlight, I mentioned this individualized starting dose, toxicities to be aware of, in addition to the general ones I've highlighted, are thrombocytopenia as well as hypertension. Thrombocytopenia rates were less with the individualized dosing there. It's important we monitor patients to look for blood pressure as well as regular full blood count monitoring in the first 4 weeks, and then blood pressure monitoring for the first 8 weeks. This led to the FDA approval, as I've mentioned earlier. So moving on to the final first-line study, the PAOLA-1 study. Now, as you know, for many patients in areas around the world, bevacizumab is standard of care. So this study is looking at patients that receive bevacizumab with chemotherapy, and we're going to have that as maintenance therapy. What the benefit of the addition of olaparib as maintenance therapy is to bevacizumab. So it's olaparib plus bevacizumab versus placebo plus bevacizumab. And the olaparib was given for 2 years. So here are the key results. As you can see, in the HRD population, there was a significant benefit with the addition of olaparib to bevacizumab compared to bevacizumab alone. Hazard ratio 0.33, 67% improvement, with the median PFS improved to over 3 years compared to 17.7 months. I'd like to also show you the HRD negative curve on the far right. There was no difference with the addition of olaparib, and that's what led to the approval in the HRD positive group only. So in terms of side effects, no new side effects are unexpected. Hypertension, we know with bevacizumab, and we are familiar with the other side effects of PARP inhibitors. It's important to note dose interruptions were around 54%, dose reductions 41%, and discontinuation rates were 20% versus 6%. And this goes back to my point about counseling patients and supporting patients through PARP inhibitor treatment so that we can try and maintain patients on PARP inhibitors for as long as possible. Okay, so that led to the FDA approval in May 2020 of the addition of olaparib in combination with bevacizumab in the first-line setting. So to summarize the first-line situation, with BRCA mutated ovarian cancer, we definitely should be offering patients, in my view, a maintenance PARP inhibitor. So either olaparib alone or olaparib plus bevacizumab, or indeed niraparib. In HR deficient patients, there's the options of olaparib with bevacizumab or niraparib. And in the HR proficient patients, it's important to discuss the results and options with our patients. So bevacizumab as maintenance therapy, niraparib, or indeed no maintenance therapy at all. So how do we integrate PARP inhibitors? First-line setting or recurrent disease? These are practical clinical questions for our patients. I'd like to illustrate this point looking at SOLO 1 and SOLO 2, first-line and recurrent disease with the PARP inhibitor maintenance therapy with olaparib. The magnitude of benefit is greater for women in the first-line setting, as you can see here, 36 months in the first-line setting versus 13 months or so in recurrent disease, although the hazard ratio is bang on the same at 0.3. The other important point is around 1 in 4 to 1 in 5 of our patients in this setting will develop platinum-resistant disease. So they'll be ineligible for a PARP inhibitor in relapse disease as maintenance treatment. And therefore, this may be the only opportunity for them to access a PARP inhibitor. Other factors to consider, of course, are patient choice, toxicity profile, the BRCA, the HRD status, surgery, response to treatment, and stage. So I'd like to just highlight two important publications which really spend some more time discussing this. One's an open access in ESMO Open. It was a roundtable discussion that I led, which is published now, as you can see, key leaders in the clinical trials, and also the PARP inhibitor guidance, the ASCO guidance of PARP inhibitor treatment in ovarian cancer. So I'm going to mention in the last few minutes the recurrent ovarian cancer trials to remind us of what we've been doing over the last few years. So this is for patients with platinum sensitive, so relapse has happened more than 6 months from their last platinum. They've responded to platinum, and then it's about randomization to a PARP inhibitor or placebo. Okay, here are the pivotal trials. Study 19 was the first randomized study. It was a phase 2. And then SOLO 2, NOVA, and Ariel 3 of olaparib, niraparib, and rucaparib, respectively. And what you see here across the board is the improvement with a PARP inhibitor versus placebo. And that's what led to the FDA approvals and change in practice for the management of recurrent high-grade ovarian cancer. So I'm now going to focus on the overall survival data, because that's what's happened in the last year. This was presented at ASCO, and I was discussant for this at ASCO 2020. So with olaparib in BRCA mutated ovarian cancer, the median overall survival was 51 months versus 38.8 months. Now, the p-value did not reach statistical significance. And we also need to remember that 38% of patients on placebo received subsequent PARP inhibitor therapy as treatment further down the line. And that's important when we interpret overall survival results in PARP inhibitor studies, because it's about access to treatment for our patients. I'd also like to highlight the treatment duration in SOLO 2. There are patients, as you can see, that remain on study. You can see the placebo as well as the olaparib, more than 5 years of treatment here in the recurrent ovarian cancer treatment space. These were the NOVA study results, germline BRCA, non-germline BRCA. I've alluded to these results. I've explained it earlier. As you can see, substantial benefit for women with maintenance niraparib. And now the overall survival data that was presented in March in SGO. So these are the results of the overall survival results of the NOVA study. And what we see in the full analysis, the final analysis, that there was no difference in overall survival in the non-germline BRCA mutated group, or indeed the germline BRCA mutated group in the overall analysis. Now, there was an adjusted analysis to try and take into account in part the availability of PARP inhibitors as a subsequent line of therapy to patients. And when this adjusted analysis occurred, we can see that there was some benefit in terms of overall survival with niraparib versus placebo. Now, finally, in the last few minutes, I want to highlight treatment rather than maintenance therapy. So not chemo followed by maintenance treatment, but this is actually treatment. So it's treatment versus effectively chemotherapy, because that's standard of care in this setting. The SOLO-3 study looked at germline BRCA mutated ovarian cancer in the platinum sensitive space. Patients were randomized to olaparib, so non-chemo, versus a non-platinum chemotherapy regimen. So what we see here is that the response rates with olaparib were higher, and you can see that in the waterfall plots there, and the PFS was over 13 months versus 9 months compared to chemotherapy. I'd also like to mention the Ariel 4 study, which again is of treatment, so rucaparib treatment in germline BRCA mutated and non-germline BRCA ovarian cancer in both platinum-resistant and partially sensitive ovarian cancer. And these results were presented at SGO in March. This was relapsed high-grade disease. Patients need to have more than 2 prior chemotherapy treatments, and patients need to be PARP inhibitor naive. So what we see with rucaparib is an improvement in the investigator-assessed progression-free survival, hazard ratio 0.67, with a median PFS improving from 5.7 to 7.4 months. I'd really like to highlight this analysis that was presented, which was looking at the PFS according to the BRCA reversion mutated subgroup. Now, BRCA reversions are known to confer PARP inhibitor resistance. We've seen preclinically and clinical examples, and this is really nice to see in a prospective randomized phase 3 study. So what we see here is that patients' PFS was significantly less with the PARP inhibitor rucaparib compared to chemotherapy in those patients with a BRCA reversion. So chemotherapy fared better there, 5.5 months versus 2.9 months. And it really introduces, the concept of actually looking for PARP inhibitor resistance mechanisms in clinical practice to guide treatment. So what are we going to consider as I wrap up here? Well, what's next? What do we need to do? How can we improve things? The real clinical question is, how are we going to treat PARP inhibitor resistance as our patients, more patients have PARP inhibitors in the first-line setting and recurrent setting. So what treatment strategies? These are all in clinical trials and ideas in clinical trials, and some of them involve re-challenge with a PARP inhibitor, or indeed combinations with another PARP inhibitor, for example. Other ways that we are looking at improving outcomes with PARP inhibitors is combination therapies. So briefly, combinations of immunotherapy, a number of first-line studies looking at PARP inhibitors with PD-1, PD-L1 inhibitors, and also the combination with anti-angiogenic agents, so bevacizumab, for example. So this is what we need to look out for in terms of the results of phase 3 studies. So my key takeaway messages from this lecture for ovarian cancer is that PARP inhibitors need to be considered as an option for all patients with advanced high-grade ovarian cancer, in the first-line setting, or indeed the recurrent setting for patients that are PARP inhibitor naive. PARP inhibitor maintenance therapy should be discussed for all patients with newly diagnosed advanced high-grade ovarian cancer. BRCA and HRD status are strong predictors of PARP inhibitor clinical activity, And therefore, testing for these markers is important to determine optimal treatment choice and benefit for our patients, and needs to be done early on at diagnosis. Discussion and shared decision-making with patients is critical. So as I've mentioned, who should get PARP inhibitors? Well, we need to consider it for all. BRCA mutated patients and HRD positive patients in particular in the first-line setting. And for HR proficient patients in the first-line setting, we need to have a balanced discussion about risk and benefit. In recurrent ovarian cancer, we should consider this for all patients who fit the criteria, who are PARP naive, irrespective of BRCA or HRD status. Testing, as I've said, needs to be at diagnosis. And it's important to consider the amount of tissue we have for these relevant tests that we need to institute. And how are we managing toxicities? Well, we need to counsel and educate our patients and our team members. It's important to monitor blood tests regularly, look for hypertension with niraparib, and across all PARP inhibitors, watch out for AML and MDS. Dose modifications may be needed early on in treatment or indeed later on, and we need to consider interruptions and dose reductions. It's really important to institute supportive measures for our patients throughout their time on PARP inhibitors. So with that, I'll close, and I'm happy to take questions. So before we hear about the impact of PARP inhibitors in other tumor types, one question was regarding combining PARP inhibitors. So one of the questions is, where do you see opportunities for combining PARP inhibitors with other agents in ovarian cancer? So I skimmed through this little during my talk, and the real key is looking at PARP inhibitors in combination with immunotherapy, so PD-1 or PD-L1 inhibitors. Other key targets are combining with anti-angiogenic agents such as bevacizumab, and also targeting with other DNA damage response repair inhibitors, for example, ATR inhibitors or WEE1 inhibitors, all in the context of clinical trials. And what's really important is that we understand the mechanisms underlying resistance so we can guide our clinical trials appropriately for our patients. So what I'm going to do now is move on to a huge area that has transformed practice now, moving on to very different malignancy, so prostate cancer. So we've dealt with some of the women cancer patients that we have, and now we're going to move on to prostate cancer. And I'm delighted to introduce and hear from Dr. Maha Hussain, who's a professor at Northwestern University in the Lurie Comprehensive Cancer Center in Chicago. So over to you, Dr. Hussain.
Thank you very much, Dr. Banerjee. And I have to say, it's very exciting time, specifically in prostate cancer, because as you know, we have lagged behind other diseases, specifically breast and ovarian. So here we are coming in, and it's my pleasure to discuss the recent advances in PARP inhibition, specifically in prostate cancer. So I would like to start with a bit of a history dating back to a little over 10 years ago, where there was research going on specifically in solid tumors, of course, and in prostate cancer. So the rationale for targeting PARP in prostate cancer starts with, again, the compelling data that Dr. Banerjee mentioned earlier. There was research showing mediation of DNA repair response to alkylator agents is driven potentially with PARP inhibitors. The PARP1 has role in cellular survival in BRCA deficient cells. And specifically in prostate cancer, there appears to be a fair amount of data indicating that AR-mediated prostate cancer cell proliferation interacts with PARP. PARP1 interacts with the AR signaling cascade, and that castration-resistant tumor cells exhibited increased PARP1 activity. And there is data also suggesting in the right side here in the diagram, demonstrating that, in fact, PARP inhibition appears to add to castration in mouse models of prostate cancer. And I'd like you to remember this because I am going to get back to it towards the later part of my talk with regard to some of the clinical trials that are ongoing. Now, one of the issues that, again, you hear both in breast, ovarian, and other solid tumors, and certainly in prostate cancer, is are all BRCA genes same? And this is from a review that we published a few years back, looking at preclinical data with regard to common BRCA genes and evidence for Parp inhibitor sensitivity. And as you see highlighted, there are different rates of responsiveness to Parp inhibition, which I think pretty much, as I will present to you the data in prostate cancer, is reflected clearly in patients that we see. Now, one of the efforts that led to the work that I'll be discussing was the Stand Up to Cancer project in metastatic castration-resistant prostate cancer, which I had the privilege of being part of the team that was involved in that project. And what we did there is we basically had patients with metastatic frontline castration-resistant prostate cancer undergo biopsies of metastatic disease, and all of the tumors underwent genomic testing. And what was very interesting is that, as you see illustrated here, and the paper was published a few years ago in Cell, that about 90% of metastatic castration-resistant tumors harbored clinically actionable molecular alterations. Metastatic castration-resistant disease also, we discovered, have a fair number of novel genomic alterations, as highlighted in there. But what was fascinating is the fact that more than 20% of the tumors harbored DNA repair pathway aberrations, BRCA1, BRCA2, ATM, and others. And somewhere about 10% also had pathogenic germline findings, which I will share with you shortly. Part of the project, the Stand Up to Cancer project, there were several clinical trials. One of the lead trials is the Parp trial, which was published by Dr. Matteo and team in New England Journal in 2015. But basically, that trial had men with metastatic castration-resistant disease that had progressed on frontline treatment, and they were enrolled into this particular trial with Olaparib, and all the patients underwent genomic testing as part of the Stand Up to Cancer effort. And what was fascinating is that there was a response rate of about 33%, with a median response duration of about 9 months. However, when broken down by the presence of DNA repair alterations or not, as you see in the graphs here, the patients who were biomarker positive had a better progression-free survival, a better overall survival, and better PSA response rates, and so on, by comparison to patients who were DNA repair alteration negative. That and the Stand Up to Cancer data provided the rationale to proceeding forward with a phase 3 clinical trial, the design of which is highlighted in here. This is the PROfound study, which evaluated Olaparib in metastatic castration-resistant prostate cancer. The key eligibility was that the patients had to have progressed on either abiraterone or enzalutamide for castration-resistant disease. They had to have an alteration in one or more of any of the qualifying genes with direct or indirect role in HRR. And then the patients were stratified by prior taxane exposure, specifically docetaxel, and measurable disease. And the patients were assigned to 2 cohorts. The canonical cohort, or cohort A, patients with BRCA1, BRCA2, or ATM. And then cohort B was any of the other alterations in there. Both cohorts, the patients were treated in a similar manner. They were randomized 2-to-1 to Olaparib versus physician choice of abiraterone or enzalutamide. This was an open label study. The NGS was done centrally with a foundation assay. At any time the patient developed progression, the endpoint was imaging progression by independent review. Anytime there is objective progression, the patients who were in the control arm were crossed over to Olaparib. Now, overall, the treatment was well tolerated. None of the patients who were enrolled generally did very well. This is the patient's characteristics, as you see outlined here. It's just a summary, both cohort A and the combination, cohort A and B. I want to highlight a few things. As you know, prostate cancer is generally a disease of older men. And while the median age was close to 70, 69 basically, I want to highlight that there were men in their late 80s and even early 90s that were enrolled in the study, again, reflecting on the feasibility of offering these types of treatments to men with prostate cancer. The most common alterations that were seen with the BRCA1 and BRCA2, ATM, and CDK12, not surprisingly, BRCA2 was the most frequent event, followed by ATM and CDK12. I want to also highlight that this is a group of men that had really very concerning disease, with somewhere about a third of the patients had visceral disease, lung or liver, and specifically in prostate cancer, these tend to reflect aggressive disease. And over 60% of the patients have seen prior taxane treatment, some of them seen both docetaxel and cabazitaxel. So again, a very heavily pretreated patient population. The safety profile overall was consistent with what's expected with olaparib, as highlighted in here. The most prominent thing, which again from the data that was just presented by Dr. Banerjee, anemia seems to be a common recurring theme, and high-grade anemia of grade 3 or greater occurred in about 23% of the patients. Other than that, there was really no different signal with regard to the adverse events observed. And there were no other major concerns with regard to offering this drug to the patients. Now, this is the primary endpoint that we reported last year. The primary endpoint was radiographic progression-free survival in cohort A. And as you see here, not only it was statistically significant, but in fact, it was quite clinically significant improvement in the median progression-free survival of 7.39 months compared to 3.55 with a p-value of less than 0.001. And I want to highlight that, as you see here in the Kaplan-Meier curve, the benefit, in fact, continued to over more than a year even, again, highlighting a very remarkable response in a very heavily pretreated patient population. These are the secondary endpoints, which is the imaging-based, again, by independent reviewer, progression-free survival in cohort A and B. And again, this was overall statistically significant, clinically significant. Pain in prostate cancer is a major adverse event of the disease itself because of bone metastases. Pain progression was significantly delayed, both in the primary cohort and in both cohort A and B. Now, we reported also the overall survival data, and this is divided by the two cohorts, the primary cohort being cohort A. And as you see here, there was a significant improvement in overall survival that continued. And in fact, when you adjust for the crossover, the magnitude of the improvement is even bigger. This is for cohort A. It's interesting to see that with cohort B, there was a trend favoring olaparib, but it was not statistically significant. And when you adjust again for the crossover, there is a relative reduction in the hazard ratio, but again, not statistically significant, but a trend again in favor of olaparib. As I mentioned, we have included 15 genes in the qualifying genes for eligibility in the trial. And as we have the data now, what's interesting is that 7 of the 15 genes that we included were of a too low frequency for descriptive, to be providing any kind of significant data. Basically, less than five patients. So 97% of the patients that were enrolled in this particular trial and were randomized, they were randomized on alterations in 8 of 15 single genes that are listed in here as you see them. There was evidence of clinical activity of olaparib in patients with alterations in genes other than BRCA1 and BRCA2. I want to highlight that the gene level analysis is complex and exploratory, and this is, again, a post hoc analysis. But again, it gives you a feel for the potential trends. Now, one of the critical issues is the fact that, as I mentioned, this group of patients was heavily pretreated, and many of them have received taxanes. After all, docetaxel was the first drug, at least in the US, to be approved for management of metastatic castration-resistant prostate cancer based on improvement in overall survival. And so when we looked at the data based on whether the patients have seen or not seen taxane and response, as you see here, in the context of the BRCA1 and BRCA2, there is benefit in both in patients who've seen prior taxane or those who have not seen prior taxane, although the magnitude of the benefit appears to be bigger if the patients have not been exposed to prior taxane. I should point out that the bulk of these patients who have seen taxane have seen them in the context of castration-resistant disease. This is the cohort of patients with ATM, and what's fascinating, it's the reverse. And I'm actually interested to see if, in fact, in breast and ovarian cancer, a similar observation is observed with regard to prior exposure to chemotherapy. But in the context of ATM patients, basically there was the control arms, which is, again, abiraterone and enzalutamide by physician choice. They appear to do better than olaparib, but the flip was true if the patient has seen prior taxane. That was not the case in the context of CDK12. There seems to be more benefit if, in fact, have had no taxane. When there is prior taxane exposure, there doesn't seem to be a benefit. Having said that, all of these analyses are really post hoc analyses, and but certainly I think can provide a potential guidance to physicians who are going to be choosing treatment as to when to time the potential use of a Parp inhibitor. Rucaparib is another Parp inhibitor that also was evaluated in castration-resistant prostate cancer. Again, in the second-line setting, this was a single-arm trial, and overall, the study was reported was well tolerated. The treatment was well tolerated. No unusual or unexpected adverse events in that regard. The rucaparib had demonstrated measurable disease responses. It has significant PSA declines and a primary endpoint of radiographic progression-free survival with a median of about, again, 9 months, and again, by independent review. With that, with these two sets of data, the FDA in May of 2020 in fact, generated approvals for 2 targeted agents. This is the first time in the history of prostate cancer that we have actually had 2 targeted therapies, rucaparib and olaparib, for patients with metastatic castration-resistant prostate cancer. Now, one thing I should point out that rucaparib was approved specifically in the BRCA genes, germline or somatic. Olaparib was approved in the panel that we have included in the clinical trial, with the only exclusion is that the patients who had the triple P2R2A gene were removed from the 15 panel gene. So the rest of the genes, the 14 other genes, in fact, have FDA approval for the use of patients in castration-resistant disease. In both settings, this is in the setting, of the olaparib, is post-frontline enzalutamide or abiraterone, and in the setting of rucaparib, it's both hormonal treatment and prior chemo exposure. The other drug that is also being evaluated in prostate cancer is niraparib, another Parp inhibitor. Again, there's early reporting of the data. It has occurred. Similar trial design, single arm, castration-resistant disease, and progressing on prior androgen receptor targeted agents. Again, no surprises with regard to the adverse events, and the results are reflected in here, demonstrating evidence of activity, specifically in both the BRCA and the non-BRCA genes. And I think what you see is a recurring theme generally, that the BRCA gene seems to kind of be the driver for the response that is seen, and measurable response disease responses, declines in PSA and CTC conversions, and so on. Again, strong signal with regard to activity. Possoperib is another Parp inhibitor that has been also evaluated in, again, a single-arm phase 2 clinical trials, castration-resistant disease, and again, demonstrating levels of activity with regard to progression-free survival and other measures of response. Generally speaking, no surprises with regard to the adverse events. And the common theme, I think, with regard to the adverse events with the Parp inhibitors is really myelosuppression, specifically the anemia and thrombocytopenia and some neutropenia. Here is the response data with talazoparib with regard to measurable disease and time to objective, again, duration of objective response by central imaging review. Now, I think with the research that we have had in this disease, there is really several lessons that have been learned. And one of the biggest questions I get asked about is really, where do you get tissue from? What is the best tissue to get to evaluate? And so on. And one of the lessons that we have learned from both the Stand Up to Cancer and from Profound are summarized in here. So the Profound trial was an international study, and the remarkable part was that the overall success rate of tissue collection and testing was actually 69%. What we learned is that higher testing success occurred in more newly collected tissue samples compared to archival tissue. Younger archival tissue, less than 5 years, was better than older archival tissue. Metastatic disease actually has a slightly better, to my surprise, a slightly better success rate compared to the primary samples, 63.7% versus 56%. However, this difference may actually be a function of two things. One of them is higher cellularity and tumor content that you see in the metastatic disease when a biopsy is done or a resection is done. And then the other part, I think, is the fact that archival tissue, specifically in prostate cancer, can actually be even a decade or longer old. And so it may not be as quality-wise as a good quality for testing. Few things that I want to share with the audience, and that is the method of collection and processing does matter. Clearly, it's important to have multiple samples from core needle biopsies and embedding it in one formalin-fixed, paraffin-embedded. One thing about prostate cancer difficulties is that what we see is not what we necessarily get when we go after, let's say, a bone site to biopsy it. And so it's very critical to actually obtain multiple biopsies, especially when we're talking about bony metastases. The other part that's very important, and I do see it till now be a problematic, especially with some of the bone biopsy archival tissue, is the fact that every time you do a bone biopsy, there's a tendency to do acid decalcification. That actually causes a problem with regard to the quality of the tissue for NGS testing. So it's very important, if you're intending to do a biopsy of the bone specifically for the purpose of genomic testing, please avoid, make sure that you talk to your interventional radiologist and avoid the acid decalcification. As I mentioned earlier to you, based on the science that was emerging some 10 years ago or so on the potential value of co-targeting AR and DNA repair, sort of to create a synthetic lethality, so to speak, setting, we actually designed an NCI-funded clinical trial that we reported in JCO in 2017. This trial basically co-targeted AR and DNA damage repair defect agent, basically with abiraterone, prednisone, and with or without veliparib. So it was a randomized phase 2 clinical trial. This trial was also part of the Stand Up to Cancer effort. And at the end of the day, essentially in the overall population, we did not see any advantage in the combination of abiraterone and veliparib. But to my surprise and everyone's surprise, we actually saw something that was not anticipated, which was the fact that the patients who had the DRD or the DNA defects actually appear to respond to AR-targeted treatment, irrespective of whether they were getting the PARP inhibitor or not, as is highlighted in here. So the first top figure shows the overall PFS, progression-free survival. And as you see here, the patients who had the DRD tumors had a much better median progression-free survival. And then when you look at the curves at the bottom, it doesn't seem to make a difference whether the patient received the single, the abiraterone, or they received the combination treatment. And that really created pretty much some sort of attention in the field. The Hopkins team went back and looked at their data set based on germline testing, and they reported comparable observation. So that led us to actually design this current trial, which we are conducting right now. It's a multi-center study looking at asking a question. If a patients have sort of the canonical DNA repair defect genes, is there a difference in terms of response to PARP inhibitor, response to AR-targeted drug, or the combination? So basically, this trial taking patients with BRCA1, 2, or ATM mutations, and then randomizing them 1-to-1 to either abiraterone with prednisone, olaparib, or the combination. And the whole idea was to really see if there is any specific signal with regard to the benefit. Now, I want to flip over to discuss some of the emerging issues with regarding to germline mutations in prostate cancer. So one thing I should point out is that this data specifically is from the Stand Up to Cancer effort reported by Pritchard in New England Journal in 2016. And basically, what we had is samples from over 690 men with metastatic prostate cancer, and they were not selected for family history or age at diagnosis. And 84 germline mutations were identified in 16 genes based on the 20 gene panel, which is highlighted here in the diagram to the right there. And interesting, somewhere overall, 11.3% of the men in the study had germline mutations. And as you see here, the BRCA2 seems to be the most prominent, followed by ATM and CHEK2 and BRCA1. Now, the mutation status, interestingly, was not associated with family history or age at diagnosis. Now, there are several other reports, and this is a review that was put by the Hopkins team, looking at the different germline mutations in metastatic prostate cancer. And what I think you could see here, there's a fairly consistent observation with regard to the type of the mutations that we are seeing, with, again, representation with BRCA2 being most common and followed by the other genes. One thing it's interesting, again, is this kind of information had led to two things. One of them is, when we're seeing patients in the clinic, when should we suspect the potential of a hereditary prostate cancer? And when should we be actually offering germline testing? And so this is a summary of the NCCN guidelines, and the uniform NCCN guidelines overall highlights the following: is that personal history of metastatic disease, high risk or very high risk disease at diagnosis, or a personal history of prostate cancer, irrespective of the risk category, with an Ashkenazi Jewish ancestry. And again, for the sake of time, I will not go through every one of these points here, but there are very clear NCCN breast, ovarian, and pancreas guidelines and prostate cancer guidelines. Now, with regard to the germline testing criteria, the point here is that it is recommended in patients with prostate cancer, and any of the following there is that, again, high risk. And what's high risk? The patient comes in with a Gleason 9 disease, clinical T3 disease, node positive disease, very high risk, as in having regional or metastatic prostate cancer, patients who have Ashkenazi Jewish ancestry, family history of high risk germline mutations, specifically BRCA1, 2, or Lynch mutations, and positive history of cancer. With regard to the somatic tumor testing, it's generally recommended to be evaluated in tumors for alterations in the HRR genes as highlighted in there. And I think that it can be considered in men with regional prostate cancer. Testing for MSI high or MMR is recommended in metastatic castration-resistant prostate cancer, and certainly it could be considered in regional or castration-naive metastatic prostate cancer, also depending on, again, the aggressiveness of the biology of the disease. There are other criteria and guidelines, specifically from the expert consensus guidelines available from the 2017 Philadelphia Consensus Meeting. And I think the bottom line take-home message that across all guidelines, all men with metastatic prostate cancer do qualify for consideration of germline genetic testing, and if positive, genetic counseling is recommended. There are different FDA-approved panels, but specifically in the U.S., GeneDx, Invitae, and Umbrae are the three panels that are approved for germline testing. So as I was mentioning, it's really very exciting time in prostate cancer and the role of Parp inhibitors in this disease. This is a slide summarizing the slew of different clinical trials, both phase 3 as highlighted in dark navy, and other trials, including combination trials with different agents, including immune therapy and radiopharmaceutical and so on. And one exciting trial that I want to highlight is the specific trial, the KeyLink 007 study, which is evaluating olaparib plus pembrolizumab in patients previously treated advanced solid tumors with HRR mutation and or HRD. With that, I would like to come to my summary points with regard to the use of Parp inhibitors in prostate cancer. So clearly, as I showed you, metastatic prostate cancer is a very complex cancer and has significant inter- and intra-patient heterogeneity. Clearly, personalized therapy and precision medicine is necessary. And as you know, this is true for probably all solid tumors short of testis cancer, but really one size does not fit all. Parp inhibitors have emerged as a promising treatment approach, and Parp1 has emerged as a promising therapeutic target. Level 1 evidence supports using Parp inhibitor therapy in germline or somatic HRR gene mutated disease with progression post-frontline AR-targeted therapy. As I showed you, there are several clinical trials that are looking at this question in the frontline setting. There are several questions, I think, to be addressed. One of the questions is, when is the best timing for a Parp inhibitor use in relationship to other life-prolonging therapies? What is the impact on response to these agents post-Parp? And I showed you some data, again, from the sort of post-hoc analyses from the PROfound trial. How do we maximize the anti-tumor efficacy? Clearly, in my humble opinion, and I'm sure you agree with me, the best cancer cell is a dead one. And the intent is right now is how do we maximize the tumor kill with the combination? The other part is, what is the impact of targeting, co-targeting AR and Parp in the context of castration-resistant disease and in the context of hormone-sensitive disease? And as you know, there are trials that are planned in that space, phase 3 trials in the hormone-sensitive space. There is clearly the issue of predictive biomarkers. I am sure that you have gone through the experience of getting the tissue and sending it, and then either it's negative or it's not adequate, and you'd have to go back again, and there's all that cycle. How about liquid biomarkers? And in fact, the FDA just approved 2 liquid biomarker assays for the utilization, for the purpose of Parp inhibitors in prostate cancer. Certainly it's easier, but I have to say it's not always been very successful for these patients. So there's really multiple issues that can confound the process of testing the patients. What about questions to be addressed? What is the potential role of Parp inhibitors in earlier disease setting and in selected patients with DRD? Can we consider it in the adjuvant setting, for example, or patients with biochemical relapse, or patients with only local regional disease, and so on? What are the long-term safety effects of the Parp inhibitor? safety is one factor, but also the duration of therapy, particularly in the context of patients who are going to live many, many years. And the issues, of course, the safety part long term. There's also the other question of response to platinum therapy post-PARP inhibitors or the reverse. In prostate cancer, we tend to use platinum treatments not frequently at all, selectively for some patients who may have a DRD situation. But the question comes up then is, does it make sense then to use the platinum or to use the PARP inhibitor and so on? And with that, I want to thank you very much for the opportunity to discuss this exciting field in prostate cancer.
Thank you so much for your presentation. I think it's really exciting as part of this session, looking at the effects of PARP inhibitors in different tumor settings, and also applying that to the different way we treat patients, like you mentioned before. Right now, not using platinum so much in prostate cancer, whereas, for example, in ovarian cancer, that's the main treatment and the backbone of therapy. One of the questions that's come through from the audience is regarding genetic testing, about the optimal timing of testing in prostate cancer. You've covered that, extensively actually in your presentation. But would you like to just summarize, the ideal setting of when you think patients should be tested?
Absolutely. So I think depending on the disease setting, for sure, following the guidelines, and the guidelines are fairly consistent in that patients who present with, again, advanced disease, patients who have very strong family history of not just prostate, but other cancers, ovarian, breast, pancreatic, and so on. These are the patients that I tend to strongly advise to go there for genetic testing. And actually, if they present with local, regional, or advanced disease, we also do, again, tumor testing, because in preparation for potential targeted treatment, in this case, right now, PARP inhibitors are approved, but there are several other potential targeted either clinical trials or hopefully down the road, different agents that might come, that might be an opportunity for the patient. One thing, at least for the US, it's important to counsel the patient. So one of the issues is going to be, if you have patients can choose to not to do it. I do think it's going to be important to explain the potential impact on first degree blood relatives. I also, though, explain to them, irrespective of what the result is, because for the majority of the patients, as you see, the germline testing is likely to be negative. That does not mean there is no implication for risk factors for their kids, for example, or brothers or sisters. So I generally counsel them that this can provide us with additional information, some of which may be used for purposes of treatment, but the other part is, again, genetic counseling with regard to family members. In the setting of patients who have who present with metastatic disease, and we are seeing a fair number of patients with de novo metastatic disease, I actually do send all testing when I counsel them and then request for the tissue to be sent in preparation for potential downstream treatment.
Thanks very much for that. So now what I'd like to do is move on to our final presentation, which is from Dr. William Gradisher from Northwestern University and the Lurie Comprehensive Cancer Center in Chicago. And he will kindly cover the role of PARP inhibitors in breast as well as pancreatic cancers. So thank you, and over to you.
Thanks so much, Dr. Banerjee. And what I've been tasked with is discussing both breast and pancreatic cancer. And I'll start out with breast. And I think everybody recognizes that there are many different subtypes of breast cancer. And there's often a misconception that BRCA1 and 2 mutations are more likely to lie in the silo of triple negative breast cancer. But I think an important thing to recognize is that because 2/3 of all breast cancer is hormone receptor positive, the absolute numbers of those patients who may harbor mutations is actually greater in patients with hormone receptor positive disease. So again, I think that this is something that's evolving in terms of how we think about this, But again, we now have a target and we have therapeutics for targeting it. So Dr. Hussain talked about NCCN guidelines as they relate to prostate cancer. I similarly will not read everything on this slide, but suffice it to say, if you have a personal history of breast cancer and are a man, if you have triple negative breast cancer or less than the age of 60, if you're any woman with a diagnosis less than the age of 45, we'd recommend that you get genetic testing. And if you fall between the ages of 46 to 50 and have other characteristics that put you at risk, or you have Ashkenazi Jewish ancestry, or other relatives with a diagnosis of breast cancer or other cancers, you may be someone, of course, who should get genetic testing. And on the right, you can see that whether you're an affected or unaffected individual, if you have some relative, first or second degree, that has some of the characteristics that I just described on the left, you would be an appropriate candidate to consider genetic testing in. So in breast cancer, there are two PARP inhibitors that are currently approved. Both were approved in 2018, Olympia, which you've heard about already, and Possoperib, both in patients with germline BRCA mutations. These are, in both cases, HER2 negative patients with advanced disease. And there are companion diagnostics that are available to determine whether or not the drug is appropriate for a given patient. What are the trials that led to the approval of these drugs? Well, there are two. One is shown here. This is the Olympia Trial. And the design of these trials bear resemblance to what you've heard in the other diseases. In this case, these were patients with germline BRCA mutations, HER2 negative metastatic disease who had received up to 2 prior chemotherapy regimens. And again, Dr. Hussain made a comment earlier about whether there might be a distinction whether exposure to a taxane or not, at least as it relates to other diseases from prostate cancer. And in breast cancer, most patients in the adjuvant setting, and certainly if they hadn't received it in the adjuvant setting early on in metastatic disease, would have been exposed to a taxane. In this trial, patients were randomized between Olympia or treatment of physician's choice, and they were given 3 different chemotherapy options: capecitabine, eribulin, or vinorelbine. And here we have the results, which show that the PFS, progression-free survival, was enhanced by about 3 months with PARP inhibitor Olympia compared to any one of those 3 chemotherapy monotherapies that could be used. And although there was no improvement in overall survival, the PFS does make this an attractive alternative for some patients. And as a result of this data, the FDA approved the drug in early 2018. So the other trial that was critically important in the development of PARP inhibitors was the Imbraca Trial. This is depicted on this slide. Again, a very similar design, PARP inhibitor, in this case Possoperib, versus physician's choice of chemotherapy. And the options were similar with the exception of the addition of gemcitabine as one of the other options. And these, again, were patients with germline mutations, HER2 negative disease. They could have received up to 3 prior chemotherapy regimens and no limit on prior endocrine therapy. And if you look at the results on the upper left panel, you can see the PFS, again, improved by about the same as what we saw in the Olympia trial, roughly about 3 months. And on the lower right panel, you see the overall survival, which again does not show a statistically significant improvement in overall survival. So in both trials, PFS enhanced by about 3 months, overall survival not yet. Now, critically important is when you compare this drug or these drugs, meaning Olympia and Possoperib as representative PARP inhibitors, to the chemotherapy that a patient with metastatic disease might get, what's the impact on quality of life? And in both cases, both trials, you can see that by getting a PARP inhibitor rather than what might be viewed as typical chemotherapy, you're able to maintain quality of life for a longer period of time before you start to see deterioration. And that pattern was seen in pretty much a complementary way in both trials. The third trial is the Brocade Trial, and this is a trial, again, in metastatic disease, HER2 negative patients with BRCA1 or 2 mutations who had not received a prior platinum or PARP inhibitor. And unlike the other trials, these patients either received chemotherapy with carbo and paclitaxel and placebo, or that same doublet of chemotherapy with the PARP inhibitor veliparib. And the primary endpoint in this study was PFS. So the essential question is, does the addition of a PARP inhibitor to a platinum-based regimen improve outcome? And as you look at the PFS on this slide, one can see that whether you look at the 2-year mark or the 3-year mark, PFS in both cases was significantly improved with the addition of veliparib to chemotherapy. We now have data by press release. We're anticipating that we will actually see the data very soon. But of course, what one wants to do with any drug that appears active in the metastatic disease setting is determine whether or not it'll have impact on patients with earlier stage disease, either in the adjuvant postoperative setting or even in the preoperative neoadjuvant setting. So the Olympia trial, which is depicted here, is an effort to answer that question. These are patients who either had a non-path CR, having received neoadjuvant therapy for triple-negative breast cancer, or post-adjuvant triple-negative breast cancer with T2 or N node-positive disease. And these patients, a large trial, over 1,800 patients, were randomized either to veliparib for a year or placebo for a year. And basically what we are hearing, again, we don't have data, is that this is very encouraging and we can anticipate to see the results soon. Now, as true with any of the other diseases we've heard about today, there's a lot going on with respect to PARP inhibitors. A lot of the strategies are really looking at combinatorial strategies, either with checkpoint inhibitors to determine whether you can enhance the immunogenicity with this combination versus either monotherapy or alone. There are efforts to look at whether adding, again, PARP inhibitors to chemotherapy in the neoadjuvant setting may offer benefit, as well as in the adjuvant setting. There are a number of trials that are ongoing, not yet reported, but we would anticipate in the next couple of years much more data coming from these. So what would be my practical points for considering PARP inhibitors in breast cancer? One is you should think about it whether the patient has hormone receptor positive or negative, HER2 negative disease. For that point I made at the outset, that there are more patients with ER positive disease than negative. And if you look quantitatively, there's going to be patients that carry these mutations. Whether you should use it at the outset is debatable because, again, if you had ER positive disease, we have survival benefit with the use of CDK4/6 inhibitors and endocrine therapy. Similarly, with the combination of chemotherapy and checkpoint inhibitors in PD-L1 positive disease, we also see a survival advantage. So how we sequence the different options that patients may have will be something that we have to look into further. I think genetic testing now should be part of the treatment for anybody that has metastatic disease. And again, for the reasons that I identified at the outset, there are patients that harbor these mutations. We now have a therapy that we can utilize. And equally important, there's data emerging that patients who have somatic mutations may be candidates for PARP inhibitors as well. And to that latter point, if you look at data that was presented and published by Nadine Tung last year, at the end of last year, looking at a small trial of veliparib in patients with metastatic disease who had other mutations other than germline BRCA1 and 2 mutations, PALB2 mutations, or somatic BRCA1 and 2 mutations that may have been detected by evaluating the tumor with NGS. It was striking that they found an 80% response rate for those harboring a germline PALB2 mutation and a 50% response rate for those with somatic mutations of BRCA1 and 2. So I think this may expand. This is a thin sliver of all breast cancer, but it may expand the number of candidates who would potentially benefit from these drugs. Again, Dr. Banerjee and Hussain also talked about the toxicity as well as the number of patients in some of the registration trials that either needed delays or dose reductions. I think the most important point that I would take away from that is when you look at all these trials together, there aren't any really novel or different side effects that patients are experiencing. And most importantly, they're all side effects that physicians are very familiar with in their day-to-day care of patients who are getting chemotherapy. So there aren't any challenges, say, in comparison to what we have confronted as checkpoint inhibitors came online. So let's switch gears and talk briefly about pancreatic cancer. So if one looks at mutations that put patients at risk for developing pancreatic cancer, this again is a table that basically collates many of the things that you're familiar with. But if you focus on those with BRCA1 and 2 mutations, not only are they at risk for some of the other cancers we heard about earlier, but also an increased risk of developing pancreatic cancer. So again, these may be individuals where one would want to do germline testing and use comprehensive panels that we heard about earlier in order to identify patients who may be candidates for these drugs. And why would that be important is based on a couple of trials that have been published looking at data in pancreatic cancer. The so-called POLO trial was conducted in patients with metastatic pancreatic cancer who did not progress after receiving first-line platinum-based therapy. So this is a maintenance strategy that you heard about when we were listening to the data with ovarian cancer. Patients would either go on to Olympia twice daily or placebo. And the data from that trial showed a doubling of the time until progression for those patients who are placed on Olympia. And one of the more striking pieces of data is in the table. And if you actually identify the patients who did respond, of course, we don't know who they are ahead of time, but if they did respond, the median duration of that response was striking. It was about 2 years. So again, the overall data from the POLO trial shows a decreased risk of progression by almost 50%. And the overall survival was not statistically significant, but numerically going in that direction. The safety and quality of life parameters were similar to all the other trials that you heard. Dose interruption, reduction, discontinuation of therapy tended to be low. And the side effects that we've seen in all the other trials that we heard about with respect to whether it's prostate cancer, ovarian cancer, breast cancer, are common across all these trials and not of high degree. So the quality of life for patients receiving these drugs is quite favorable. So Olympia was approved for pancreatic cancer in December of 2019. And these are in patients with deleterious germline mutations of BRCA1 or 2 and had been stable on 16 weeks at least of first-line platinum-based chemotherapy. Now, I think what we've heard from the other speakers today is that, of course, monotherapy is interesting. Perhaps combining it with some of the standard chemotherapies have also been shown to enhance the effect. But where we're really going to be directing our interest in clinical research is combinatorial strategies, either with immunotherapy, other targeted therapies, DNA repair inhibitors such as WEE1 inhibitors, and pro-apoptotic drugs that may all enhance the effect of Parp inhibitors, or vice versa, the Parp inhibitors may enhance the effect of these other drugs, including immunotherapy. So these are really the subject of ongoing trials in many parts of the world, and we look forward to hearing those results in the near term. In breast cancer, we only have Olympia and talazoparib. In pancreatic cancer, Olympia, but this is the spectrum of drugs that are out there. We've heard about many of them with respect to the diseases we talked about today. But if you look at the list, there are many other areas of oncology where these drugs are being evaluated and hold promise. So with that, I'll stop and be receptive to any questions.
Thank you very much. This is a question for all of us, I think, but perhaps I could start with you in terms of PARP inhibitor resistance. We've seen across the tumor types discussed today the use of PARP inhibitors, which will be increasing. And for the majority of patients at some point, there may well be further progression events and PARP inhibitor resistance. So what do you think, say in breast cancer, how is that being addressed at the moment in terms of clinical trials? And are there commonalities across ovarian cancer, for example, and prostate cancer, how we can all work together on trying to look at shared mechanisms?
Well, I'll just offer some generalities, and that is, I think you made the point that, we see in some patients reconstitution of the ability to repair DNA. And we also are starting to learn that combinatorial strategies may enhance the effect of these drugs or possibly reverse resistance. Those are really the subject of trials now. So I don't think we really know with any certainty. We do know that anybody on a Parp inhibitor with either pancreatic cancer or breast cancer who has metastatic disease will become resistant. The question is, can we overcome that with any of these other strategies?
And in ovarian cancer, there's the OREO study that is waiting results for, which is about re-challenging with a PARP inhibitor in patients that have progressed on a PARP inhibitor. So having platinum-sensitive disease and then re-challenging with olaparib. Are there such studies in prostate cancer, for example, or breast cancer, or pancreatic cancer, looking at re-challenge of a PARP inhibitor?
There's really not much going on, at least in prostate cancer, that I am aware of, because platinum is not part of the standard of care treatment. There's a lot of talk about it. We discuss it. There are some potential institutional trials, but platinum doesn't seem to play a big role right now just because of really very limited data, to almost no data.
In answer to one of your questions, in ovarian cancer, the majority of patients receive paclitaxel up front in combination with carboplatin. So it will be difficult to really assess a no prior taxane group of patients, although there may be some, but very interesting concepts shown there in prostate cancer. So I think the key thing in terms of PARP inhibitor resistance is for us to all work together really across the tumor types, and that's what I've learned today through this session about how much we can learn from each other treating multiple tumor types. What's really clear is that also beyond BRCA, there are different tools being used to assess evidence of homologous recombination deficiency, whether it be panel testing for certain genes or whether it be assays, functional assays, or assays looking at scars for homologous recombination deficiency. So I think it'll be very exciting next few years ahead in this PARP inhibitor arena. So on that note, I'd really like to thank my colleagues, Dr. Sassane, Dr. Gradishar, for joining us and me in this comprehensive discussion. Thank you for joining us.
Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/VHU860. This activity is supported by independent educational grants from AstraZeneca, GlaxoSmithKline, and Merck & Company Incorporated.